Good morning, everyone. Welcome to Grand Rounds. I want to begin with some very sad news that our distinguished and beloved founding director of the Division of Substance Abuse, Herb Kleber, passed away last weekend while traveling in Europe with his family. The cause of death isn't precisely known, but it seems like it may have been a heart attack or a stroke because it happened suddenly. But Herb was an iconic figure because he really was one of the founding pioneers of addiction medicine and sort of stimulating the biomedical research enterprise and the medical community to focus on substance use disorders and addiction as a clinical condition and to develop a research emphasis and a body of knowledge that could support treatment. His work in every place that he went was incredibly productive, contributory, and valued, and not least of which was the time he spent here. And probably the best indication of that is the numerous individuals that he mentored who have gone on to be very prominent researchers and clinicians in this field. So he will be deeply mourned. For people who might be interested in attending, there's going to be a funeral service at the Riverside Memorial Chapel in Manhattan on Sunday, this Sunday at 12:30 p.m. And in lieu of any kind of flowers or anything else, donations should be sent to the College of Problems on Drug Dependence. What's that?
It's a NIDA-supported organization. It's a scientific organization.
Okay. Okay, so it's a NIDA-sponsored organization for substance abuse disorders, so CPDD. Well, that should be in the announcement we send out. Also, on the topic of substance use disorders, there's going to be a conference that we're co-sponsoring with the Smithers Foundation. That's going to be held on Friday, October 19th. It's at the Stewart Hotel. Where's that? Midtown? Midtown Stewart Hotel. Announcements going out about that. But it's going to be a day-long meeting on the topic Building a Bridge from Research to Treatment. And it's going to focus on evidence-based research and clinical practices and prevention and treatment for adolescents and young adults suffering from substance use disorders. Just quickly, Meg Haney, one of our faculty in substance abuse, received a 5-year grant, R01 from NIH, for a project entitled Cannabis Relapse and Influence of Tobacco Cessation. And Reuben Robbins received a 2-year R21 from NICHD on using mobile technology to improve assessment of neurocognitive impairment among perinatally HIV-infected youth. So congratulations to them. Well, today we have a real pleasure of drafting one of our faculty and also one of our colleagues in the New York State Office of Mental Health into service as our Grand Round speaker, and that's Dr. Lloyd Sederer, who serves as the Chief Medical Officer of the New York State Office of Mental Health. In addition, he's co-appointed here in the School of Public Health as a lecturer and adjunct professor. So Lloyd is a native New Yorker. He went to Bronx Science, then he went to City College, then he graduated for his MD at State University Upstate in Syracuse. He interned there and then completed his residency and was on the faculty at Harvard and McLean, where he rose to the position of Senior Vice President for Clinical Services. He then followed the then CEO of McLean to Washington when Steve Marin took the job of CEO and of the AP, American Psychiatric Association, and Lloyd served as let's see, what was your title there? As clinical director, and did a stint in the APA within the Beltway, representing our profession. But then returned to New York subsequently and served in a variety of roles in New York City in public mental health administration, culminating in his role as the Executive Deputy Commissioner for Mental Health Services for the New York City Department of Health and Mental Hygiene, serving under then, I think it was Commissioner Tom Frieden, who went on to head the CDC. But then with a lot of persuasion and the fortuitous appointment of Mike Hogan as the Commissioner of Mental Health in New York under initially Governor Spitzer. Got all these people that Frieden, Spitzer. He was drafted into service for the state as the Chief Medical Officer and has continued in that capacity. So I have three bosses, the CEO of the hospital, the Dean of the Medical School, and the Commissioner and Chief Medical Officer of the state of New York, so make sure you pay attention and applaud since Lloyd is one of the bosses. But Lloyd has had really a very unusual and important career in the sense that while he's done the academic thing in terms of doing research and publishing in scholarly journals, he's carved out a role for himself as a writer communicating to the lay public through various media platforms. And those include such publications or internet news sites as Huffington Post, Psychology Today, U.S. News and World Report. He writes reviews of movies and theater in addition, and he's become quite a prolific author. So we have within our faculty a number of very talented people, literarily speaking, who David Hellerstein has published a lot, Robert Klitzman's published a lot, I even published something, but Sid Mukherjee, Andrew Solomon, pretty distinguished company, Sylvia Nasser. And Lloyd has published, I don't know what the number is, but The Family Guide to Mental Health Care, The Diagnostic Manual of Michigas, a parody of DSM-5, Improving Mental Health Care, 4 Secrets in Plain Sight, and most recently, The Addiction Solution, Treating Our Dependence on Opioids and Other Drugs, very timely. This is also described in various fashion on internet-based videos, including a TEDx talk and YouTube. So, he's turned into quite a polymath and Renaissance person, and we're glad to have him as part of the psychiatry department, even though he can't have an official appointment because it's a conflict of interest. But Lloyd will present based on his research in putting together this book, and then he's insisted upon us having discussants, and the best qualified person to do that will lead off, which is Francis Levin, and then I will mop up in whatever way I can, and we'll then engage you all with some questions and discussion. So please join me in welcoming Dr. Lloyd Sederer.
Thank you, Jeffrey. It is my great honor and privilege to be here. I also have to mention that Deborah Cabanas and I have co-led a writing workshop here in the department, and we're now in our 15th semester, and very proud of that and the work that comes out of that from so many great colleagues. No talk as well on addiction at this point should overlook Herb Kleber, as Jeffrey said, an extraordinary man and unbelievable contributions, and I'm thankful to him. When I came back here to New York City in 2002 was the year that buprenorphine was released, and I worked with Herb around the propagation, the use, implementation of buprenorphine here in New York City, and then subsequently, great man, great loss. So I'm going to talk about the opioid and other drug dependence, the epidemic that has gripped our nation, where the death toll continues to rise every year. And my approach to this is as a public health doctor, because the public health has beat back many an epidemic. You know about that, from polio to smallpox to reducing driving deaths to reducing the morbidity and mortality from tobacco, from changing the landscape of HIV/AIDS. And the same principles apply here in this epidemic, and unfortunately they're hardly being employed, and that was why I wrote this book. The talk has 3 parts. The first part is what we're not doing. The second part gets more humane, and it talks about we human beings as active ingredients in our experience of using a drug, that it's not just the drug, it's the drug-human interaction. And then the third part is the solutions part. So as to what we're not doing, Winston Churchill summed it up very well. You can always count on Americans to do the right thing after they've tried everything else. And we continue to try everything else. Well, there's some new ground being broken federally, but not much. Even the money that was recently appropriated is largely around enforcement and interdiction, not so much about prevention and treatment. And this reliance on things that don't work goes back some time and probably gathers, if you will, into 2 principal areas. One is consequences, one is control, and the other is consequences. Control is trying to interfere with a person's access to a substance. And we have a very long history about trying to do that, and a history of one failure after another. Probably the best example of that is prohibition. Remember that? Federal law. And the one lasting legacy from prohibition was the development, massive development of organized crime. When we try to interfere with people's access to substances, they appear in another way, and organized crime is right there to capitalize on this strategy, and has and continues to do so. So that's control. Consequences is scare tactics. And the idea of interfering or getting in the way of human beings' access to intoxicants is rather preposterous, because there is not one society on Earth that doesn't use intoxicants. Some people argue that that's as much evidence as a drive as is a hunger or attachment or sex. So control. The effect of the control, as I just was saying, is summarized by this headline in The Onion, a satirical newspaper: drugs win drug war. They always do. The war on drugs was a term that was introduced by Richard Nixon. And Nixon's war was actually a political strategy to win the South. This was called the Southern Strategy, in order to arrest and incarcerate lots of people of color and hippies, both of whom he had no kindness for. And his war on drugs was particularly focused on those individuals, on those populations. And it involved undercover acts, border interdiction, burning crops. These are the strategies. This is what happens, actually, when you try to wage war on drugs, because you can't wage war on drugs, so you wage war on people and countries. You might think that this is a photograph from a raid in a foreign country on insurgents, looking at the armaments of the military. This is actually a photograph taken in a town, a small city here in the United States, not in New York. And these are local police who are armed to a fare-thee-well. Look at their shields, look at their high-power guns, their their Humvees. How could local police obtain this kind of armament? Well, the federal government has expiration dates on all of its armaments. And when the shelf life is over, the federal government offers all these tools, these weapons, to local police, and some of them to pick it up. And this is just part of the escalation, and it's part of the response to the fact that when law enforcement uses more powerful weapons, drug dealers use more powerful weapons. And the terrible irony of all of this is that in recent years, it's not just people who are dealing drugs who are getting shot, but police have been shot, and some of them have been killed in these raids. This is a deadly war. It takes its toll on people. The other consequence of the war on drugs occurred when Reagan doubled down on Nixon's strategy and made law enforcement and incarceration his principal solution to the use of drugs in this country. And over the years, we now have at this moment over 2 million people in jails and prisons in the United States. And when we look at the demographics of this population, it's hugely people of color and poor people who can't represent themselves, who are there for life sentences, and the predominance of them are there for nonviolent drug crimes. So the hammer of enforcement falls disproportionately on people of color and poor people, and that's another consequence of what we're up to. And when you see these strategies, these law enforcement strategies, this is what happens. The other strategy that we're particularly fond of in this country, renewed again in this administration, is to scare people, particularly young people. And this is a poster probably from the 30s about cannabis, about marijuana, about how it's going to destroy your children, how it's going to destroy your brain, reefer madness. And here the paradox actually is that trying to scare adolescents has the opposite effect, because the adolescent brain is wired for risk and adventure. Just think about this from an evolutionary point of view. You want the adolescent to leave the hut, to leave the village, to find new sources of food, to find another mate. So when we put in front of a youth the prospect of risk and adventure, they're drawn to it. And the worst example of this strategy was the DARE program. Have any of you actually been in school and been part of the DARE program? Yeah. So the DARE program was sending police in uniform to schools, sometimes dragging a felon with them to say to the kids, this is what's going to happen to you. And again, risk is an enticement for young people. This strategy does not work. Second part of the talk. This is about human beings being active ingredients in their experience, we human beings, in our experience of drugs, and that in order to build an effective approach to drug use in this country, we have to look past the drug, because it's not just the drug alone that explains people's behavior. And that's true of cannabis, it's true of poppy, it's true of all the psychoactive substances. And there are a number of factors, and I'm going to illustrate them. Anybody recognize this woman? That's Billie Holiday, yes, arguably one of the most accomplished blues singers in this country. And she was born, her mother was a prostitute working the streets of Baltimore, and she was raised on the streets of Baltimore by her mother, sort of raised. And at 10, she was raped on the streets. And her screams brought the local police, who took her to be a prostitute and arrested her. And then she spent the subsequent year in a youth detention center where she was abused and scared to death one night, locked in a cell with a dead body. This was to try to deter her from that profession. She went back, she was released, she followed her mother a few years later to Harlem, here in New York, where her mother was working in her brothel. And her mother refused to take her in. So here she was, 14, penniless, homeless, and she became a prostitute herself. A few years later, the New York police arrested her. She went to Shelter Island, a predecessor to Rikers, where she served her sentence. And the first thing she wanted to do upon her release from jail was to get as far away from her experience as possible. And she did that using high-proof alcohol and very soon heroin. And this factor is called set. This is the interior. This is what we individuals bring to our encounter with the drug as individuals. And this is a term, as will be the next one, that is borrowed from Norm Zinberg. So she became a heroin addict, and that addiction lasted throughout her life. She died at age 44 in a hospital from complications of drug and alcohol use. This is Set, and today we think about her life and her experiences as adverse childhood experiences: neglect, abuse, rape, incarceration, drug abuse in the home. These are all risk factors that our youth are exposed to, and almost invariably fate that youth to mental and physical illness by the time they're adolescent. It's almost a miracle that people who have a life like she did don't develop an addiction. That's Set, that's interior. So if there's an interior, there's an exterior. And that Zinberg called setting. It's the circumstances that are involved in the use of a drug. And this is a picture from 1971 from Vietnam, where we had over 500,000 combat troops. And word got back to the Defense Department that the troops were heavily using heroin, which was very potent, accessible, cheap in the jungles. And they asked Norm Zinberg, who was a professor then at Harvard Cambridge Hospital, to go to Vietnam and to answer two questions. The first is, what's the prevalence? How much is this use going on? And second, are these soldiers going to bring back their addiction to the States, thereby potentially doubling the heroin using population in this country? And he went with an epidemiologist, Eli Robbins, and he reported that 1 in 5 soldiers were using the high-potency heroin 3 to 7 days a week. And he explained this use by his term setting, the circumstances. Imagine being a soldier living in the horrific tropical jungles, not knowing whether you would be alive or dead at the end of the day, not knowing who the enemy was. It could be a child, it could be an older woman, and fighting a war that was unpopular in this country. He called that setting, and he predicted that the soldiers would not bring back that same rate of heroin use to this country. And he was kind of right. It fell to about 12% from 20%, still bringing back a large heroin use population of veterans, and we see that still to today. And we understand more about that. We understand how combat trauma changes the psychology of a person, the neurocircuitry of a person. That's called setting. Age is another factor. And this is, any of you have adolescent children? Lucky. I don't. We did. So cannabis is ubiquitous. starting in junior high school, everywhere in high school and thereafter. And what we've learned is that it makes a difference whether a young person smokes or ingests cannabis when they're 12, when they're 20, or when they're 30. And that's because our brains are under construction. I'm going to take some liberties with a lot of neuroscientists in the room here because I'm no neuroscientist, so I'm borrowing, well, as best as I can from what I've learned from you people. But here's the process of maturation, myelinization, which allows for better communication from different regions of the brain, and over time for better impulse control and better frontal lobe power. And the brain under construction is affected by high-potency cannabis, and the stuff that is available now is 60 times more powerful than the stuff that I smoked here in college in New York City, where I used to have to take this incredible inhalation because the stuff was so damn weak. Now it's 60 times more powerful. Have any of you been to a dispensary, a legal recreational dispensary? Okay, well, we'll come back to that in a moment. So for parents, what do you say as a parent? You know, you can try to just say no, but of course that's been a strategy that's been tried and failed. So it is about helping youth appreciate that their brains are under construction, and the message is wait as long as you can, protect your brain as long as you can, rather than imagine that the kids won't use. Another factor in terms of our experience of substances is the route of administration. What do you think is the fastest route of administration to the brain? You're going, what does that mean, snorting? No, it is not snorting. And it is not intravenous injection, it is inhalation. So just think about the anatomy. If you put something in your vein, it has to travel up to the heart, pass from one chamber to the other, go down to the lungs, and then up to the brain. And that is truncated by inhalation, where the cerebral arteries are immediately infused with the substance. The fastest route of administration to the brain is inhalation. And some people explain tobacco addiction as problematic as it is because of the rapidity by which high-potency nicotine reaches the brain, route of administration. This also helps us understand coca. Coca leaves are chewed for a lifetime in the Andes. Cocaine has been a perennial problem, but the only epidemic was when cocaine was inhaled, crack cocaine, route of administration. There are other factors. These are summarized in my book and elsewhere. But one I wanted to touch on with you, because this gets back to your visiting dispensaries or your family members visiting dispensaries. Because when you walk into a recreational marijuana dispensary, first of all, almost always the first person that you encounter is somebody wearing a bulletproof vest and carrying a big sidearm. Because these are all cash businesses, because remember, cannabis is illegal federally. So none of the banks, none of the credit cards will allow for purchase of cannabis. That's a cash business. Cash businesses mean that there's somebody with a gun to protect the money. And when you walk in, but if you ever have a chance to do this, you should definitely do it. You don't have to buy anything, but you should definitely do it. It's like going into a fine wine store, and somebody very knowledgeable comes up to you, greets you in a kind way, and on the tables there are all of these bell jars, glass bell jars, filled with different types of cannabis. And there's usually an iPad next to it explaining the composition of what you're looking at. And here's the important point, because when cannabis grew naturally, which hardly happens any longer, it was 5 feet tall, and it had over about 100 cannabinoids, but the two principal ones were tetrahydrocannabinol, THC, which gets us high, and CBD, cannabidiol. And the ratios were often 60 to 70% THC, 20 to 30% CBD, and CBD is neuroprotective. And it helps prevent a youth or an adult having some adverse reaction, anxiety, psychotic reaction in those who may have brains predisposed to mental illness. And there is research underway right now to see if CBD can be made into a commercial antipsychotic agent. So I say to my son, who's grown, and he lives in a state where it's legal, that when you go into a dispensary, make sure you buy the stuff that has 20 or 30% CBD. You know, your brain's not that invincible. And that's a message here in New York, because we will have recreational cannabis probably within a year. There was a report issued by the health department, basically, that the governor used to support this, and this is one of his initiatives. And so you won't have to travel to Massachusetts or California or Colorado to go into a legal dispensary. And you'll see that you can get stuff that is really just too strong for your brain, or you can mitigate the stuff that you or your friends and loved ones
Lloyd,
use.
are the medical dispensaries of cannabis products similar to the recreational ones?
Yes, and I have never been, frankly, into, even though there are a dozen here, I've never been into a medical marijuana dispensary. But I believe that the choices, there are probably not as many choices, but there are choices. Fran, is that? Yeah. So solutions. And again, this is my approach here is as a public health person. And public health has some basic foundational approaches: prevention, detection, early intervention, effective treatment. And that's the script for any epidemic like this one. So on the prevention side, we have a number of effective, proven, low-tech interventions. One of them, my favorites, is called LSD Life Skills Training. And this is pitched at different levels for different kids, and this is a school-based intervention. And it is not about trying to scare kids. It is about teaching them cognitive skills, which are not in great supply when someone is 12 or even, gray-haired like me. We can train youth, and we can train others around cognitive skills. A 12-year-old at lunchtime, where another kid comes up to him with a blunt and says, "You want some?" has to process that offer, and with skills can say, I've got soccer practice at 4 o'clock. I have a test tomorrow. Maybe not today. That's cognitive capability building in young people. And the other very long-lasting program, not very well used, is Big Brothers Big Sisters. And we know that the presence of an older youth from the same background as another child is actually protective in terms of reducing the use and dependence on drugs. Those are youth prevention. And if you have prevention with youth, it's a good idea to have prevention with families. And this is also a skill-building program for parents or other family members of kids who are 10 to 14. And it is about positive parenting. It is about learning how to be positive as a parent. And I wish that somebody had knocked that into my head when my son was young and first born. And because I was just too tough on the kid, and that drives somebody away. And positive parenting creates the bond, the necessary bond that is protective. And here you see a picture of a family at dinner, and Obama, when he was president, every night in the White House when he was there, had dinner at 6:30 with his 2 daughters and his wife. No texting, no television. This was about creating a family unit, and some of the research years ago at CASA showed that having dinner with your kids is protective against drugs. So this is right there. This is low-hanging fruit that is very low cost. So prevention. Here, I want to thank Dr. Melissa Arbuckle and her group at the Neuroscience Curriculum Initiative. And I hope you guys download this graphic or take a look at the video that accompanies it, because it's what you may want to use when you're trying to explain to a person with an addiction or to a family member what they need to look for, what they need to get in their treatment. Because good treatment actually targets a variety of areas in the brain. Because this is a bad disease, and it's really hard for people to master. So you want to give them as many points of intervention in the brain as possible. So here we have the ventral tegmental area. This is where I told you, I take some liberties with neuroscience, nucleus accumbens. And this is where we experience pleasure. This is where we have the hit of dopamine that starts a cycle going. And consequently, this area, as Melissa and her colleagues called, is like the gas pedal. This is what starts things going. And we have now, for over 15 years, very powerful interventions in this area, and they're called medication-assisted treatment. They are opioid antagonists and opioid agonists. That's where they act. Then there's the orbital frontal cortex, and that's where we experience, that's where motivation is thought to reside, where we have the experience, I like that, I want more of that. That's the orbital frontal cortex, and that's where motivational interviewing works. Have any of you trained or used motivational interviewing? Okay, well, 29-year-old woman walks into her pediatrician's office with her 6-year-old son who has a recurrent ear infection. She sits down in the doctor's office, and the doctor, before writing her a prescription for antibiotics, starts to say to the mom, "Don't you know that smoking in the house causes recurrent ear infections? Don't you know you're poisoning your child with secondhand smoke?" And you see the mother there squirming in her chair, can't wait to get out of the doctor's office and isn't going to go back. That is not motivational interviewing. So just rewind the tape, and the mother is sitting with the pediatrician, and the pediatrician says, "Oh, I see here that you're a single mom. That must be a handful. And that you have a full-time job. Wow, that must be hard to balance your work and your child, it must be really stressful coming home. I can understand why you would smoke." That's the doctor talking, not the patient. I can understand why you would smoke. This is about getting on the side of the patient in terms of their experience, that they're using a substance for a reason. And what happens, and then the patient may protest, and the doctor repeats, so that pretty soon the patient moves on the motivational fulcrum to the point where they're saying, "Well, doc, I'm not so sure it's such a good idea." The very thing that the doctor wants to say, and we have to bite our tongue not to say. And that's the moment where there's an opportunity to say, well, like what? what might you want to do? Here are your options. When might you want to do? That's motivational interviewing, and it works there. Then there's the prefrontal cortex, such as it is, where our reasoning and judgment are thought to reside. And we can strengthen the work of the frontal cortex with support groups, 12-step groups with smart recovery, an alternative to 12-step. This is where we can amplify the effects of the prefrontal cortex. And then last, but certainly not least, the amygdala and the hippocampus, where we believe memory is encoded. And we learned a lot from Dr. Blasey Ford about memory very recently in terms of how memory is encoded. And it's encoded when there's an emotional charge, and even more so when there is terror. And remember Pavlov's dogs? So Pavlov conditioned his dogs to salivate to the bell, not to the food. This is a conditioned response. We all have conditioned responses, and relapse in addiction is principally driven by cues, by triggers, by conditioned responses. Listening to somebody on the phone, a friend who calls who's high, seeing a deal being made on the street, Prince dies, doesn't matter. These are the triggers, and this is where cognitive interventions, this is where relapse prevention works. So if you are ill with an addiction, or you are counseling somebody or their family, use this graphic, because otherwise it's too hard to understand. It's a complicated thing, but it is about urging families to try to find comprehensive treatment, which is really hard to find, but it makes a difference. Each of these interventions is additive. Two other concepts, running almost to the end now, but important in this whole field. Simile, these are both Latin terms, similia similibus curantur, and spiritus contra spiritum. So similia similibus curantur, that means like cures like. And this is the foundation of Alcoholics Anonymous back to the early 30s. It takes an alcoholic to cure an alcoholic. And in more recent times, past 20 years or so, this is the essence of the peer movement in mental health. And if you want to help engage somebody with a serious mental illness, retain them, peers work. Then the other is a Latin pun that Carl Jung used in a letter to Bill Wilson, one of the co-founders of Alcoholics Anonymous. Spiritus contra spiritual life is needed to fight contra spirits, to fight alcohol. And that too became a foundation of 12-step recovery and resilience in general. We've learned here in New York City after a variety of big disasters, 9/11, Sandy, that having faith, having a spiritual life actually is an important predictor of who's going to recover from the trauma. And then medication-assisted treatment. This is where our field, the medical field, can make the biggest public health difference. Because the two life-saving drugs that are available now are Suboxone, buprenorphine, and naloxone. Naloxone being the antagonist. I forgot to bring it up, my prop. I have a couple of the spray things in my briefcase, and I urge all of you to keep them. I haven't yet to use one of them, but a friend of mine in another state was in a gas station. Somebody wouldn't come out of the bathroom. They opened the door, and there was a guy lying on the floor with a needle in his arm, and you don't even have to use a needle. You can just use the nasal sprays. So this is about, and this city, and New York City has done a lot to make naloxone available to every family and every person who's using drugs with other people. But and the story with buprenorphine is that after an overdose, the risk of death, it goes up exponentially. in the next 6 to 12 months if somebody is not prescribed buprenorphine. These are the two life-saving drugs that are hardly used, that so few doctors, nurses, now PAs actually have the waiver prescribed buprenorphine. These are the two life-saving interventions that would reduce death, morbidity and death from opioids. The premise of my book is that people use drugs for a reason, that they use drugs to escape physical pain, psychic pain, or just to transport themselves away from everyday mundane and grind. So you have to offer alternatives. But the one I want to touch on actually is psilocybin. And there's research going on here at PI on psilocybin, and the work in psilocybin started some years ago, and over 500 people with facing imminent death, terror about their imminent death, were administered 1 or 2 doses of psilocybin. Over 5 at the University College of London, at Hopkins, at NYU, at Stanford, and 80% of these people went from that state of terror to being reconciled to their death, that there was a transformation in their mind. This was not during the trip, this was as a result of the trip. And so it's now being researched for refractory depression, for addictions, OCD. We have no single intervention, 1 treatment or 2 treatments that could actually make a lasting difference with addiction or depression or OCD. Everything is a maintenance treatment with variable success. So I bring this up because you may see this more widely available in the years to come, and that's because it is a transformative drug and it's safe. And I'm not suggesting that after this talk you call your friends at NYU or Hopkins and try to get a supply, or go downtown somewhere to the East Village and get some, but rather to keep an open mind, because this may represent the most promising new treatment in drug use that we have. And then finally, stigma. This is about us. This is about how we may talk the talk. You know, addiction is a brain disease, but how welcoming are we in terms of people who have addiction in our offices, in our clinics? Because they are hypersensitive to judgment, and if we're housing it, they'll feel it and they won't come or won't return. So here's a shameless last slide. This is the book that this is taken from. If you like the stories, the history, there's more there. So thank you very much, and now we have some comments.
Do you want me to talk from here and then, okay, great. I'll keep my comments I'll try to keep them brief. I tend to like to talk, so I'll try to keep it brief. My goal was to comment on the book and just talk from my own personal experience and what I felt as I read the book. One of the first things I'd say is that I really found this book a breath of fresh air. It took me at least a month to read Dreamland, which is this opus, because I read like a few pages at night before I go to bed. And it goes through in exquisite detail. Sam Quinones wrote this book, and it's a masterpiece in its own right as well. But it goes through in excruciating detail how we got into the opiate epidemic. But at the end of the book, you're sort of left with, what do we do? Like, you're left with, oh my God, this is horrible. And actually, frankly, some of his suggestions at the end, I felt uncomfortable with some of the things. Being an ADHD expert, I sort of got a little irritated when he said that the reason that we shouldn't have kids on medication with ADHD, and maybe that's part of the addiction process. So I thought he went off the deep end at the very end. But throughout the whole, it's a masterpiece, but it leaves you with this hole. And I think what was different and what I really enjoyed about Lloyd's book was it does provide very concrete and easy to understand solutions and potential solutions that we could apply. And I think it's something that I'm going to be recommending to patients and families to read. I think it's very readable, and you give a beautiful description of set and setting with Billie Holiday and other examples in the book, and I thought that was really terrific. One of the things that really rang true for me, and I'm going to quote your book in saying this, is how we need to understand how these substances serve the users. The warm opiate rush rivals any other state of euphoria and dissolves psychic and physical pain, that marijuana acts as an anxiolytic, lysing nervousness, that alcohol is the universal solvent to unique social inhibitions. And I think as psychiatrists, we tend to think this way, but often when you talk with other people in the field, they don't realize the positive aspects of what drugs do for people. And I remember Alan Leshner, who was the head of NIDA before Nora, said people use drugs to either feel better or feel good. And I think there's a lack of emphasis on feeling better, and while it's very hard to, quote, prove the self-medication hypothesis, certainly when you sit with patients and you ask them what got them involved in drugs, often it's about underlying anxiety, depression, ADHD, impulsivity. And you know, one of the things that people often ask me is like, why would a patient with schizophrenia use drugs? It makes their psychosis worse. Well, they often feel better, or they still feel good with it. It decreases anhedonia, at least by their report, and it makes them, often, the most poignant thing I heard an adolescent say to me one time was that at least he could have a label that he could fit in, that it was almost better to be using pot and using drugs with other teenagers rather than deal with the fact of his psychosis. So I think we need to understand and interpret that it may not be specifically to improve psychosis, but it's some other factors that are reasons why people use drugs. I liked Lloyd's description throughout the book about the fact that luckily most people, this is another take-home message, use drugs and don't develop a drug use disorder. Even with cigarettes, 1 in 3 wind up with a problem with cigarettes. Luckily most people don't. And these other factors that Lloyd brings up, I mean, Herb Lieber drummed this into my head for many years: setting, and availability. You can have set and setting, but if it's not available to you in some way, either psychologically or there's a lot of lack of support for using. One of the things that people are very concerned about right now is that adolescents are much less likely to view marijuana as harmful, and usually with the reduction in harm, in the perception of harm, use tends to go up, and there's data supporting that with marijuana. The other thing Lloyd emphasizes is that addiction is a disease, and while I think most people in this room may accept that, I can tell you that even among other medical professionals, that isn't the case. There are people who write about addiction not being a disease, Sally Sattel and others. So if we still have some controversy over that as an issue, then you can imagine where the lay public would be about this. And I think most people are not totally convinced that addiction is a disease. And I think when we don't view it that way, it leads to a lot of stigmatization and moral failing and all the things that we all know. One of the things I happened to do this weekend, I don't know if anybody has seen A Star Is Born yet, the newest version, but it's a wonderful movie, and Lady Gaga and Bradley Cooper, thank you, is excellent in that. But I felt it was a lost teaching moment. Of course, you know, when you go in as a specialist in an area, and I'm sure for dramatic reasons it had to be the way it was, and it's been that way in the other 3 or 4 versions of this movie in the past. But the thing that was sad to me was the treatment recommended. This was an individual who had heavy use of pills, alcohol, had ACE, as Lloyd is mentioning, clearly depression, had made a suicide attempt at 13, and what was the treatment he was offered was a rehab in AA. And that was sort of like a lost moment, and nothing describing about his psychiatric illness, which occurs in more than 50% of patients who have a substance use disorder. And of course, for the movie's purposes, I understand, but it really was a very unfortunate. I was sort of girding myself as I was watching this, because this is not what treatment should be in the United States in 2018. The other thing that Lloyd did, which I liked a lot because I didn't know as much about it, is about primary and secondary prevention efforts. You heard some about it. If anything, I would have liked, because I don't know as much about it, I would like to have heard more about primary and secondary prevention. It certainly has a lot of face validity. Maybe as a scientist, I would have liked more data regarding it, but I'll trust you that there is data out there. But I would have liked to have heard more, because I think doing these kinds of common sense solutions, again, coming with my expertise in ADHD, Brooke Molina and others have written that when parents are monitoring their kids, like they know where their kids are, not asking the parents, do you know where your kids are, but asking the kids, does your parent know where you are? Which is a very different question. When parents really had that monitoring and involvement in their kids' lives, even with the risk of ADHD, the use of drug use went way down. So, you know, parents are a big tool that we often don't think about using enough of. He mentions a number of solutions in terms of treatments. I loved your diagram and describing that, and that was described in the book. Melissa's diagram, yes, I appreciate Melissa. But, you know, one of the things that I'm going to say that's a little controversial, Lloyd went to the point in the book to say he doesn't want to disparage AA, and I don't want to disparage it either, really, but maybe I'm going to now, because to not provide or at least offer medication addiction treatments, assisted treatments, the question whether to call it addiction or assisted, it should be mainstay, so let's not even call it assisted, let's say medication addiction treatments, that there's an 80% reduction in overdose if you have people on these medications. And many places in the country aren't training their residents. Luckily, we do training here in buprenorphine and Vivitrol, hopefully. But the fact is that most of the treatments in the country, over 80% of them, don't really offer any treatments other than AA and 12-step. And 12-step has worked. I've had a number of patients of mine with particularly alcohol dependence going for treatment using AA, but AA itself is not a treatment. There are programs that say that they're 12-step facilitation, but primarily if a patient goes there, they have to agree to be involved in AA. And one of the points in Lloyd's book is that we should be meeting patients where they are. There should be some choice and shared decision-making. And in most of the treatments in the United States, that's not the case. So what's occurred is you have the AA 12-step machine, which exists throughout the country, and then you have like methadone programs, which have, let's say we're talking about opiates, in parallel to that. And often the two interventions have never really deal with each other. And unfortunately, if you go to most treatments in the United States, treatment programs, you'll be lucky if you get CBT or motivational enhancement. It's not standard, and it's very hard for patients to access them. So I think we have a lot of work to do in terms of improving treatment. Why did this all happen? My opinion, I think physicians abrogated responsibility for the treatment of addiction. Even though the AMA recognized alcoholism as a medical illness back in 1956, I don't think that was really bought into by most of the medical profession. Even now today, me and many other faculty members are arguing with hospital administration to get addiction treated in the hospital, and it's a hard sell. So we have a long way to go. But I think we're on the right path. I think Lloyd's book was terrific. And I won't say any more than that. I'll stop there. Thank you. Thank you for such a good book.
Well, so, Lloyd, I'm going to compare you to Donald Trump, not because you're a New Yorker, but, the information that the public receives regarding health care, mental health care, substance abuse is limited and often inaccurate or distorted. And what Lloyd's done, and I think this comes out of his inclination towards public health and public mental health in this case, public service, is to try and sort of bypass the interlocutor, which are the journalists or the media, to provide it directly. It's not an easy thing to do, and it's not what we went to medical school or graduate school to do either. But it's successful, and unfortunately, you find that the most successful people who are doing this are like the Dr. Oz's or the Dr. Phil's or the Keith Ablohs, and they're more into showbiz and self-promotion than into communication of constructive, needed information. So, Lloyd's done this. He, must have been like a closet writer, but he went to medical school like a good Jewish boy. And, he was able to successfully sort of merge these things. And so he did so regarding mental illness in general, and now addiction and substance use disorders. And it's an important sort of task to take up, and all the more so because of what Fran said, which is the medical profession, and this is really reflecting attitudes of society, just ignored substance use and addiction historically. I mean, you said 1957. Okay, well, that's pretty late, given the fact that it's been a problem affecting humankind for centuries, if not millennia. And it was left to the faith-based approaches, to do it on their own. And they came up with these faith-based 12-step approaches, which maybe are overly dogmatic and, eschew the integration of medication or medical forms of therapy. But, you can sort of forgive them for that, or at least understand that why that might be the case. Nevertheless, the challenge is how to get the best of both worlds, particularly since the resourcing of healthcare service delivery to substance abuse and addiction is far less than optimal, and is really impeded by not just the policy and the lack of resources, but also this kind of arbitrarily forced separation between substance abuse and mental illness. So, medicine was really late to the game and has now embraced it, as NIDA and IAAA programs like ours, would indicate, but it's really still $1 late and, a day late and $1 short in terms of supporting it. But then you get into another question, which is, it's not a unitary problem. I mean, it's really multifaceted. You have socially appropriate forms of recreational intoxicants, which may have in their own health hazards, but we're big boys and girls, and we can make our own decisions about how to use them. Caffeine or nicotine or alcohol, now cannabis. But it's not the same as opiates, and it's not the same as stimulants, and it's not the same as hallucinogenic substances, or it's not the same as sedative, barbiturate type substances, not the same as glue or inhalants, but these are being used. And so, the approach to treating them is going to be varied, and I'm not sure that we have, kind of a substance specific. And then you get to the point, you run into the problem is that, most substance use is not, it's polysubstance use. It's not, single, although there may be, more culpable substances that are predominantly used by different populations. So the therapeutic approaches, and then, you get back into the issue of there is some ideological tension in terms of what kinds of treatment can be brought to bear on these various things. And then you have the issue of your age thing, what stage, if people are in the experimenting stage versus the, chronic use stage, and depending on what substance they're using predominantly, it's going to require a different approach. And then you have the issue, or the factor that's, I think, NORA as well as NIDA has been very effective in introducing, which is substance abuse is not, is something that changes the brain, or I guess the term they use is hijacks the reward system. And so when you're treating somebody who has Alzheimer's disease or multiple sclerosis or any kind of progressive disorder, the stage at which you're treating them obviously influences the type of therapeutic approach and the potential prognosis of the individual. So one of the hardest things, I think, to make the public understand and the government understand is that individuals may come to substance use and repeated use and then dependence and then addiction through various ways, some of which they can be blamed, or some of which their parents can be blamed, or some of which their circumstances are causal to, like Billie Holiday. But once they're into it, they're like survivors of some kind of accident, or stroke survivors, or because their brain is altered. And you're talking about something which is either rehabilitative or regenerative. And the point is that the complexity of this problem is so much greater than is appreciated, and the level of support and attention that it's receiving as to, the Onion article is not really, facetious. It's no wonder that we're not winning the war on it, and it's because of just historic neglect and vestigial or persistent bias. And in that sense, substance abuse is appropriately grouped with mental illness and psychiatry and mental health care, because the whole thing about mental illness treatment is also one which has suffered from this historic neglect. So I think there's a big policy and education challenge that is needed to be able to address this appropriately and get the kind of attention and level of support that's needed, which brings us back to the fact that Lloyd, by virtue of his efforts in communicating through media outlets, is really paving the way for hopefully taking up this process or this pathway of engagement in a greater way. What was the last thing I was going to say? Movies and TV. Yeah. I mean, forget it. I mean, they've had their way with truth in medicine and science, for ostensibly artistic license or dramatic purposes. But shame on Bradley Cooper. He did Silver Linings Playbook, and that was pretty good. That was really good. And then this, and maybe he was trying to hew to the original script, and he didn't want to deviate by putting in something that would be a teachable moment. But good luck getting, Hollywood and, television to sort of cooperate in that regard. But in any event, the other issue, and I don't have anything to say about this, I'll just raise it as an imponderable, is what is it about our culture or our society that impels people maybe more than other places? I mean, sure, there's genes, because everybody doesn't get addicted, but there's susceptibility factors, there's the external, internal setting factors that you alluded to, so there's a lot of it has to do with socioeconomic and sociologic factors, but there's also cultural factors. I was at a meeting, I was saying earlier this week or last week, this week, was a meeting earlier this week on mass violence. And it was a meeting which brought people from different disciplines together, and I was the mental health psychiatrist, and then they had people from the social sciences. And this one guy from social sciences, I don't even know what department, but somewhere in Harvard, and he was talking about cultural factors that seem to be contributing to the increase or the persistence of mass violence among males largely, and usually young males. And he was alluding to cultural factors which had to do with like machismo and the desire to be able to stand up to something, to assert yourself in terms of action. And I was thinking more than South America, more than the Middle East, and he was making a case, which was a very thoughtful case, as to how you quantify that, how you address that is, I mean, you're talking about going into the culture wars, maw of battle to do that. But when you see statistics about the American Indians with the increase, Native Americans with the increased rates, the Eskimos, when you see these, like the study that came out of Princeton showing that lower middle class or lower class, whites, particularly white males, having a decreased longevity because of factors which include substantial increased rates of alcoholism and substance abuse. It adds sort of at least legitimacy to the idea that cultural factors are contributing to this. So I'll end with that, and we'll take questions from anybody who wants to ask one. So, Lloyd, thank you for doing this and provoking the discussion. Fran, thank you. And the floor is open to questions or comments. Yes, Jonathan.
Dr. Sederer, I wonder if you could comment on how successful you've been in shifting the governor and the legislature from interdiction, incarceration to prevention and treatment. How's that for a short answer?
Personally, I don't think I've had any effect, but I am proud of many things that have happened here in New York State. It was a few years ago under a previous governor that about 20,000 men and women, principally men, were released from the state prisons who had been there on drug charges, and many with life sentences. And that was a moment of terror, because what was going to happen when 20,000 were released, and nothing happened. That's one thing. The state's investment in trying to increase the services, addiction services, is probably greater than any other state, or per capita. But it's impossible to do without the federal money. So I think New York State and this march towards cannabis, recreational cannabis. I've tried to take a cautionary note with the health commissioner and others because of this issue of access, that we increase access to anything, we increase use, and because the composition is unregulated. So, but I think New York State has got a lot to be proud of.
Let me give fair warning to Clarice, Bill or Anka, and to Steve. And I'm going to ask you to comment from your respective populations that you focus on about how this issue of substance abuse and addiction is represented. But in the meantime, I want to ask Denise Kandel, who has spent much of her career focusing on the issue of pathways to addiction, if she wants to sort of comment on this. So why don't you give Dr. Kandel the microphone?
Yeah, this is a very difficult question. And I'm very often asked, how do you feel about the legalization of marijuana? So when we've translated the epidemiological findings into animal models in which you can change the sequence of presentation. Well, let me step back and say, the idea is the gateway hypothesis assumes that if you use drugs in a particular sequence, and you find this epidemiologically, and the issue is, does the use of a particular drug, quote unquote, cause you or increase the risk that you're going to use another drug? So the way to address this question, I think, best is through animal models, because in animal models, you can change the order of presentation. So if you see, in human populations, 95% of the people who use cocaine have used marijuana, okay? So in the lab, you can take two drugs, A and B, and you can prime the animal first with A and see how he reacts to B, or you can do the reverse, do B, and see how it reacts to A. So we've not done and published work having to do with this order, the sequence of the effect of priming between nicotine and cocaine, alcohol and cocaine, and beginning work on marijuana, mainly using synthetic cannabinoid VIM on cocaine. And what we find in every single case is that there is a unidirectional effect from, let's say, nicotine to cocaine, so that if you prime an animal with nicotine, they react much more to cocaine. You do the reverse, nothing. Same thing with alcohol, and now we have preliminary data on cannabis. And the thing that's really interesting, in fact, yesterday, there was a lab, much of his work has been in collaboration with my husband's lab.
Who's your husband?
Eric Kandel. And yesterday, there was a lab presentation by someone who's doing work on cannabis. And what's really interesting, when you do the work, you find that the priming effect of cannabis, let's say on cocaine, only occurs among adolescents, not among adults. And, they're able to, and it seems to affect the prefrontal cortex. And what I think there's an experiment that needs to be done now, which I'm going to suggest they do, is to take the adolescent rats who've been exposed to marijuana and then see how they behave as adults, because we know that adolescent exposure, the earlier you start using a drug, the more likely you are to continue using it as an adult and use it heavily. And I think we also need to understand how, because we know that the brain, especially the prefrontal cortex, doesn't mature until early adulthood. And, so we need to, with these experiments, to try to get a better handle on, how is this correlated to the neuroanatomy. And I said, you have to look at early adolescence, postnatal day 30 and 40 and 50 and 60. But, this may be kind of boring experiments after a while. Anyway, so that's what we've done. Do you have questions? I'd like to answer them, but don't ask me about the neurobiology.
Any comment? Well, I mean, the question that it raises in my mind is that, does that mean that if we should think about with youth, if they're going to smoke, give them, what's the Pfizer drug I'm thinking of? Chantix, cannabidiol, or naltrexone, as an antagonist to whatever the priming effects might be. That's easier said than done, but just wonder. So Clarice, youth is like the sweet spot for, beginning
Well, I
this.
have a few comments to make. I don't treat drug addicts. I send them to Herb Klaber. That was always, because I'm too narcissistic to think that that person would rather have alcohol or a drug than me. And I let them know right away that, young people, that if they're going to really be addicted and use drugs, et
Well,
cetera.
but by that time, but when they're seeing you, they're not addicted for the most part.
No, but I'm saying,
they're
so
experimenting or they're
what I
potentially.
give, I do treat plenty of kids. And the problem is that they go to a party and other people are smoking and they don't know, they think they should take it too, or they won't be popular and they won't be with the in-group. And it's very hard to teach them to say, it's like, if I had diabetes, I can't take the sugar, I'm allergic, et cetera. But one of the things that really worked on an individual basis, and this is for years, I've done this with kids who are not true addicts, where they really do need a different kind of program. And what Herb helped me a great deal with these kids. But what I would say is it'd be a group, and somebody would say that he smoked pot on the weekend, and the other kid says, well, you don't say anything about Jimmy smoking pot, and you tell me that I can't do it. I said, well, let's find out. Jimmy, what are your grades? Straight A's. And when you woke up this morning after being out all night at the party and smoking, how was it? Fine, I could take, and he's fine. I said, okay, so Billy, what are your grades? Well, C minus. I said, well, what happens when you take a drug like Jimmy? Well, he feels very groggy for 3 days, and he can't concentrate, and he can't study. I said, okay, so who here has the learning disability? Every single person has somebody relative with a learning disability or something. So I said, well, if you even have that, it's going to have the reaction that Billy had. So it's on an individual basis. Kids will listen when you tell them this. We're not talking about legalities. We're not talking about the law. We're talking about the effect on you. And if you really get a very careful, like Lloyd was saying, and Francis, you get a good feeling of, are they really, is the only thing that makes them happy, they're really depressed and anxious, or is something they're doing to be cool?
Yeah, well,
And that can be worked with.
It's kind of a motivational interviewing. I mean, it's an improvised, individualized motivation. But Lloyd, what do you have to say about that, though? We don't want to have seat of the pants sort of treatment of substance abuse. On the other hand, is there something there that Clarissa's been doing on her own?
A beautiful example, and I think it illustrates also just how complex and nuanced these problems are, but no really big problem is without complexity or nuances. That's what we're facing into. Dr. Kendall, I don't know if implicit in what you were saying also is that that sequence, that knowledge about sequence may have a harm reduction element to it, that we might be make more accessible one drug wouldn't lead to another, or vice versa, from a public health point of view, if we actually knew some are not gateway and some are. What would we do from a public health point of view?
Or what's worse, is cannabis or tobacco, I mean, does one act as more of a primer or facilitator than the other? So, Anka and Bill, I'm wondering, within the LGBT population, because substances may be different ones are preferred, or the severity may be greater, but what are your impressions?
Certainly, we know that the rate of substance abuse is increased in the sexual and gender minority populations, but I'm not sure I can address your question, but something that I've wondered about is that SAMHSA has guidelines for addressing substance use in sexual and gender minority populations, and we focus on the role of early stigma, and I guess creating the set that leads to substance dependence. But then I know of very few programs for treating substance abuse, even though those who specialize in the LGBT community, who actually use the SAMHSA approach and address the stigma. Instead, they say that focusing on the stigma essentially condones the drug abuse, or gives the person an excuse to continue using, and that the focus of the treatment program has to be first on abstinence before those issues of stigma can be addressed.
This is stigma regarding sexual orientation and practices, as opposed to substance abuse.
Right. The early stigma that might be associated with childhood gender nonconformity or lack of acceptance by family, peer rejection. Mm-hmm. So I'm just wondering, how, what people's thoughts are about, how to best address substance dependence in this population with the background of stigma.
Yeah. I mean, I would agree with you. There's actually very little research in this area. And, one of our fellows, Jeremy Kidd, who's actually particularly interested in transgender youth, and he's finding higher rates of alcohol dependence. He's working with Walter Bocking and other people in your group, Tanda, I'm blanking on her last name. But, and one of the things that he's coming across, he's doing qualitative interviewing with individuals, transgender youth who were involved with alcohol and drugs. And what he's finding is that there's a lot of issues around role identification and interpersonal relationships and such not. And one of the things he's been talking to Myrna Weissman about is modifying IBT, which may be particularly relevant for this population, and incorporating substance use treatment into it. It's sort of a combination therapies. There's all these combinations out there, like mindfulness with cognitive behavioral therapy, and I think IBT, I think, has been underutilized in substance abuse treatment, and I think combining that with other traditional treatments might work particularly well, but it's an open area. I mean, Jeremy is he's very junior, he's a fellow, but he's being asked to talk all over the country already because there aren't that many people in this area. So there's a lot of work to be done.
By the way, the speaker was William Bine, who's a psychiatrist, recently joined our faculty and is going to be heading up this program of providing mental health care services in the correctional system to transgender inmates. So speaking of the correctional system, Steve left. He ran away. I was going to try and get somebody to comment. Well, anyway, one more question. Yes, Maddie.
That working in the, is this on? Yeah.
Yep.
Working in the area of suicide prevention and, working with families and so on, question often arises with regard to differentiating, quote, accidental overdoses and suicide. And it seems to be really an overwhelming dilemma to try to differentiate the two. And I was wondering if you had any thoughts about how to try to figure out whether it is accidental or whether it's intentional. And you talk about risk-taking behavior, and it's on a continuum in so many ways. And so we don't have this is a longer, much longer answer, and it's right at the end, but it's something that, it's now, I'm trying to grapple with, with that question more and more.
So did Prince die by suicide or just accidental overdose?
I mean, I think one of the things.
Use the microphone.
Another
Use the microphone.
Another monkey wrench in this is that, now heroin is mixed with fentanyl, and fentanyl's 50 to 100 times more potent, and now there's even more other numbered compounds and whatever else. So it's becoming even more difficult to determine whether or not it's been an overdose that was intentional or not. I think often what I hear from patients when I talk with them after an overdose has occurred is that it's a sense of they didn't necessarily want to kill themselves, but if they died, they've been in so much pain, it wouldn't have been the worst thing in the world. So it's sort of this in-between kind of thing. I think we obviously have to take it very seriously when somebody has an intentional or an inadvertent overdose. But I think often it's much more things are relayed as an unintentional overdose, because unless somebody leaves a note or they've told providers that they were that they were suicidal, that it was intentional, it gets put into an unintentional. So I think the 70,000 drug overdoses that we have in the United States this year, probably a lot of, a substantial minority of them were intentional, but they're not getting recorded that way. I don't know if you...
Thank you. That's such an important point, and there may be some overlap here between relapse prevention and safety plans. Both are aimed to address a person's vulnerability, their triggers, and what they can do at that moment to stay alive, because if they use, the likelihood of dying, it just keeps going up because of the stuff that's being peddled.
So in conclusion, let me just ask Lloyd, what kind of review did you give A Star Is Born?
I write a lot of movie reviews, and I went also this weekend, and I was more favorable. You're right about missing the opportunity about medication, but I actually saw all 3 prior versions, which is a truly painful experience, which I don't recommend to you. One of them is 2 hours and 55 minutes with an intermission. That's the Judy Garland one. So, but they did emphasize that, Cooper did, that addiction is a disease, and when if you ever compare the treatment that James Mason got in his locked up prison of a rehab center to what Bradley Cooper, so they were more kindly to the problem, but more could have been done.
All right, well, we'll have you back with Bradley Cooper to discuss this next time. So thank you, and everyone was invited to lunch upstairs.